Hello, everyone. Good morning, good afternoon, good evening. My name's Joel Robinson. I'm a member of the GMI Partnership based in London, and I want to give you all a warm welcome to our international panel event on MPV response. We're looking at community responses to MPV amongst gay, bi, and men who have sex with men. So I'm really delighted that we've got a really brilliant panel for you. I'm just going to briefly introduce them. And then as I'm talking, do feel free to start thinking of your questions that you might want to ask us. You can type those in the YouTube channel or on the platform that you're in, and we'll be able to receive them. So we're going to do some introductions, and then we'll start with the first question, and then we're hoping that this will be quite an interactive event. So yeah, do have a think about what questions you want to ask. So I want to start with our US colleagues. So I'm going to just say hi to Ace. Ace is, he works on the West Coast mainly of the States, and he's the Chief Executive Officer of Pierce County Prevention Program. And yeah, so he's working in a kind of fairly urban context, and particularly looking at health issues for Black and brown folks, and yeah, really working on HIV prevention and support as well as MPV. So really warm welcome, Ace. It's great to have you with us. And then we've got Murray Penner, who is in Washington, D.C. on the East Coast. So welcome, Murray. Murray is the director of, let me just get it right, because it's two things I want to say about Murray. So I always think of Murray as the director of the U=U campaign, which he's got his shirt on there as well. So undetectable equals untransmissible, and also the Prevention Access campaign. So you might know that campaign, big international campaign. So welcome, Murray. It's really good to have you with us. And Murray's going to be talking a little bit about Washington, D.C., and also maybe cover a little bit of what's happening in neighboring New York. So yeah, really warm welcome. And then our other three panelists are neighbours to me. They're in London, in England. So I'll start with Marc Thompson. Marc is the co-director and co-founder of Prepster and the Love Tank Community Interest Company. And we're sort of co-hosting this webinar tonight with the Love Tank. We work really closely with them, the GMI partnership that I work for, on community responses to MPV and HIV in London. And Marc's particularly focuses his work on Black and queer communities. And he's been an HIV activist for many years, ever since his diagnosis in 1986. So delighted to have you with us, Marc. And then I'll introduce Harun. So Harun has joined us. He's a sexual and mental health activist and speaker, positive speaker. And he's joined us today, particularly to share his own lived experience of acquiring MPV recently. And well, really, it's quite a story, the dramas and the pain and the issues that he's had to face. So absolutely delighted that he is joining us today to share more of a lived experience perspective. And then finally, last but not least, it's Susan Cole. Many of you may well have seen Susan on the airwaves. She's a broadcaster. She coordinates AIDS Map broadcasting, so often doing panels with clinicians and community advocates for HIV prevention and support. Susan is also an activist and has had a long history of working on issues to do with HIV. She's also a trustee of many charities, and she also really focuses on looking at communities of colour and also women's lived experience around HIV and other health issues. So really great to have you with us as well, Susan. So we are going to particularly focus on sort of comparing and contrasting community approaches. We're going to use the term MPV to describe what some people will know as monkeypox. Some people might know it as MPX. We're going to avoid using the term monkeypox where we can, because it's quite a triggering word, the word monkey. I was talking to Ace the other day about British colonial history and how the word monkey has been used as a racial slur. So we're going to kind of stick to calling it MPV today. Hopefully you'll be able to catch up with us and keep up with us there, and hopefully you'll appreciate that. I think, you know, most of us could be more sensitive in the world around racism and our colonial history here. So we'll be talking about MPV. And then I just want to remind you, especially if you've joined us a bit late, you can post in, you can tweet us, you can post on Facebook and in the YouTube channel. So any comments or questions, we'll see them and we'll weave them in to our live broadcast. Okay, so I'm going to start with a question. It's just a general question, just to give the panelists all a little bit of time to just describe what you think are the successes of the community approach to MPV where you are, and then maybe just if you let us know what maybe one or two of the successes, and you know what's working well, and also one or two of the challenges. So something that a challenge that you might be facing. And I'm going to ask Murray to kick us off.
Thank you so much. It is really an honor to be with you all today, and just to talk about my experience here in Washington, D.C. I think as it relates to your question, Joel, one of the successes that we've enjoyed here, I believe, is the community's response, and the community really stepping up right off the bat. I mean, even before we saw, you know, vaccinations coming forward from the health department, there was a lot of community buzz. There was a lot of conversation. I'm in several social groups. I am a cisgender, gay, obviously white, male living with HIV, and I'm involved in a lot of different social groups. And all of the groups were talking about this. It was the real topic of conversation. It wasn't about the parties that folks wanted to go to or the events that anyone wanted to go to. It was, what about this monkeypox thing, this MPV thing? And so, you know, there was immediately a call to learn and to educate others in terms of what we knew, what we didn't know. Obviously, in the very early days of the outbreak, it was very similar to back in the early days of the HIV epidemic. We didn't know a lot. We were learning as we went. We were flying the plane, and it wasn't even all built yet, you know? So, and I think we're still doing that. I think we are still learning more and more about the response. One of the things that I think was successful here in DC also was a very, very early vaccination clinic. Now, that comes with some challenges as well. Obviously, if you're, reading the news about the U.S., you know that we suffered some severe vaccine shortages very early on. There were very few vaccines, and that, of course, was very chaotic in terms of a rollout. It was one clinic way on the north side of Washington, D.C., and so if you didn't have the means to travel there, if you didn't have the means to get there during the day, say you were employed and you couldn't take off work, that was certainly a challenge. Since then, we have gone to 3 clinics in different locations with different and better hours. But nonetheless, when I walked into the clinic, and I was one of the first, privileged to be one of the first individuals getting vaccinated, the waiting room looked white. It looked like me. And that was concerning right off the bat for me. I knew that was going to be a challenge. I think it's still a challenge in Washington, D.C. Washington, D.C., for those that don't know, is a relatively small community without the suburbs of about 700,000 people. And whites and blacks are about equal in terms of percentages. There's about 45 of each, and then the rest are obviously Latino and mixed races. When you look at the The cases in Washington, D.C., they skew highest for Black and white individuals, but also very disproportionately for Latino individuals. And when you look at vaccinations, it gets even worse in terms of that equity. And so I think that's the biggest challenge now, is really our equitable approach to vaccinations. And let me stop there and pass it back to you, Joel.
Thank you, Murray. That's great. It's really great summary. And I know we're going to ask some more specific questions about some of the things you said, particularly equity and vaccines, in just a minute. So now I'm going to ask Marc to come in, and then after Marc, I'm going to ask Harun, and then I'll come to Ace and then to Susan, just so that we know the order of things, so I don't have to put you on the spot so much. So over to you, Marc.
Thanks, Joel. And it's really wonderful to be here, and also to have this international conversation, I think is really, really important. So I think the first thing that kind of springs to mind is when you ask about how the community responses, we have to ask, who do we mean by community and who makes up our communities? Because they're multiple, right? And I think that overall, I think we can look and go, yes, the community of men who have sex with men have responded really, really well. And I think particularly in the early days of monkeypox, of MPV being discovered and being understood. And I saw lots of chatter on social media, lots of groups having conversations, lots of men wanting information because they were swimming in a pool of misinformation or a lack of information. But I think that what happened is quite quickly that some of the narratives started to come out, wheedled out some of those men. So we talked early on about men who are having lots of sexual partners, men who are higher risk, particular groups. And so I think for that, some men kind of pulled themselves out of that narrative. So younger men, Black and brown men. And it reminded me again of the very, very early days of the HIV epidemic, which I'm sure we will talk about later on. So I think that that was a bit of a misstep for us, that we weren't kind of considering, actually, we've been here before and we know that the cascades happen, and it just takes a handful of cases and this will slowly trickle down. If we first of all start talking about men who have been to sex parties in Berlin being most at risk, we soon forget it's going to be a 22-year-old who's literally just jumped onto Grindr for the first time. And so I think that's probably the error that we made. But I am pleased to say that the community has come together. And I want to kind of take it back a little bit. I've seen organizations in the UK really come together to manage the response, to speak to people like our health agencies, to work really closely with clinical and healthcare professionals to try to ensure that the right information is getting out there, to hold government bodies' feet to the fire, to challenge them as well. So I think the grassroots community activism which we have here, which is quite strong, has really, really worked really well. You asked about successes, and I think obviously the initial rollout of the vaccine program, when that was first available, was a success. We got lots of men in those queues and got them vaccinated really early on. What we certainly saw were those were overwhelmingly white guys, cisgendered men, men of a certain age, men who were able to get to a clinic and spend all Saturday and Sunday in a queue. So I think the success that has come out of that is some of the community-based response, which I'll talk about a little bit later. But I think obviously the biggest challenge that we continue to face is access to vaccine, number one. But secondly, some parts of our communities still were not on board with this, didn't quite understand that it impacted them, didn't have information or resources in not necessarily home languages, but in a language that they might understand, that the vaccine wasn't made available to them in places that was accessible to them. So for one to get a vaccine at the time, you needed to queue up, you needed to book appointments. All of these things kind of made it a lot more difficult, a lot more challenging. And these are the things that we've seen around health inequities for years. So we're repeating a lot of the same mistakes. And I think those were the challenges that we certainly faced and we continue to face.
Thank you, Marc. And we're going to bring in Harun now.
Thank you, Joel, and thank you for having me. Well, actually, Marc and Marie actually summarized everything that I can say from a patient perspective. But what I can say as somebody who had MPV, community response was the greatest success I ever seen, because I've been living with HIV since 2016, and the community response got me going since then. And then with MPV, I saw the same thing, because I was in the hospital, and when I shared my first post, I really didn't expect to wake up lots of messages. And then waking up lots of supportive messages from community, especially HIV community or sexual health community, the clinics, the consultants, and all the support was so great to see. And like Marc said, when we were looking for an information, unknowns are much worse than any condition out there, and it was a total unknown. And the response from organizations, voluntary sector, was actually to inform people, to give the correct information, right information, and then to spread the word, to create awareness campaigns. While the negatives of the downside of is that lack of communication from the government or from authorities, the community tried to fill that gap in, and they did a great job, I think. And activism and advocacy just got to a different stage here in the UK to cover up the holes and to support the people who are going through that journey. And it is sad to say that in the early stages, and I must say still it is like that, the only information came through a couple of organizations like Love Tank or Prepster or iBase, as well as people, only few, who shared their journeys on the social media. And that was the only source of information, which you expect more than that when it comes to public health. So that was the community response was good side of it, and it showed us the lacking side of the authority and managing public health. And that's all I want to say for now.
Thanks, Harun. And I'm going to bring in Ace now.
Great, thank you. First and foremost, I want to do a land acknowledgement of where I am today. A land acknowledgement is making clear representation of the people who were here before me. I am standing in the ancestral land of the Tongva people. My organization is in the ancestral land of the Puyallup people. Why this is an important conversation here, now, and forever is that we're talking about displacement and who has access to care. And so right now I'm in a country where 47% of people diagnosed most recently with MPV are Black African American, followed by 23% being Hispanic Latinx individuals, followed by 27% being white non-Hispanic individuals. And I'm also in a country, if you want to compare those numbers, where only 13% of the population is Black, 19% is Latino, and almost 60% is white. So you don't have to be a math major and epidemiologist to know that, just like COVID-19, just like HIV, this is becoming an issue about race justice. So when I look at the rollout of the MPV response, it looks very similar to the rollout of protease inhibitors in 1997 of HIV treatment. White people first. After that comes other kinds of white people, then another set of white people, and then we'll worry about everyone else follow therein. I'm in a country right now when HIV prevention, there's a treatment available called for PrEP. So we already know that the majority of individuals who are utilizing PrEP are white identified, as opposed to the reality that Black and Latinos are the most impacted. When it comes to treatment as prevention, a lot of the work that Murray is doing around U equals U, we know if you break down viral suppression rates based on race, white people are the lion's share. Like we have a member of our CDC who used to be in New York City. His name is Dr. Dimitri Daskalakis, says, in the United States, we have achieved our HIV healthcare goals for the white population and no one else. And MPV was no different. So when we're looking at the individuals who are acquiring, progressing, and going untreated, we know what they look like, because they're coming in with progressed disease, and they're also coming in with no idea what's happening. Because in the circles I run in, MPV is not a conversation. No one knows what MPV is. It's a larger piece of the conversation. And then, this is a global conversation when we're talking about vaccine access and vaccine equity. When we're looking at the countries that are most impacted with progression and unfortunate morbidity, we're talking about places like Nigeria. We're talking about places in West Africa who have almost no access, like slightly under 1% of vaccines are available in that parts of the world. So this is a global conversation about race justice, because we know prevention, treatment, and education is not equitable. And it's never been equitable, like whether we're talking about HIV, whether we're talking about COVID, STIs, viral hepatitis. MPV is just another addition of this has been a really great response if you come from a particular community and are connected certain ways. I think what Murray was saying, like when Murray said that, oh, I went into a clinic and everyone looked like me. There were so many individuals in my population who did hear about MPV, but they showed up at these clinics in their neighborhoods, and then they were filled with, it looked like for lack of better language, a white gay circuit party. These are all the individuals who push out all kinds of racism in the club setting, and they're like, I'm not going to this place in my neighborhood that now looks like the part of the city that I don't go into. Because Murray's speaking about, like, DC is split into 4 quadrants. It used to be white people were only in 1 quadrant of DC, and the other 3 were all black. And now, like, how gentrification is, black people are being pushed out of DC, and they're massively being pushed out of the healthcare market. So these are the conversations that I'm glad we're having today, because this is a race justice conversation more so than anything else. Because we I'm tired of looking at individuals who have no idea what's happening in their body, and they're progressed. And if they came from a different community, they would have heard about MPV. They would have learned about prevention if available, and they would have heard about treatment if they had acquired it. Thank you.
Thank you, Ace. And it's great to hear, just very directly how it's affecting folks that you work with. And just in a little bit, we'll bring in a sense of how we can compare and contrast what might be happening in the other cities as well. So, and finally, I just want to bring in Susan. So I know it's always slightly hard to speak last on a question. So
yeah, no, absolutely.
It'd be great to hear your insights. So
yeah, I mean, I think all of my esteemed colleagues have raised so many crucially important points, but I'd just like to speak a little bit more about what Ace was mentioning. I think monkeypox, like COVID, like HIV, is fueled by global health inequities, both globally and also within countries. I mean, we're certainly seeing that people of colour are disproportionately affected in the UK, and that's very much the case in the USA. But we need to remember that monkeypox has been endemic in African countries for decades, and people are just completely seem to be forgetting about this. We only seemed to get interest in monkeypox when it was white bodies that were being affected. And I think it's absolutely shocking that that in countries where monkeypox has been endemic, people don't have access at all in many of the countries to the vaccinations. And there's so many parallels to what we saw with COVID-19 and what we saw with HIV. I mean, I think it's fantastic that the community has mobilized, and again, there's so many parallels to HIV there. But I think one of the issues that we're seeing in the UK is a lack of funding. Our health services are being overwhelmed. A lot of our sexual health services are so focused on monkeypox that things like access to PrEP is being affected, access to contraception is being affected. So we're likely to see a knock-on effect from there. And then also, just in terms of information, it's brilliant that we're sharing information, but unfortunately, I don't feel that we're necessarily reaching communities most at risk with that information. And I think it's so important that the people who are leading campaigns about monkeypox are people from the communities that are most affected.
Thank you, Susan. Yeah, and thank you for sort of summarising a number of key issues. And I think we'll probably want to jump off and stay on the theme of racial justice and equity. There's a number of questions that we're getting on the platforms. So there's a little bit about, do we know anything about plans for vaccination in parts of Africa? But there's also some quite strong questions on there around, what what can we do then about inequity? You know, what can we do in our programs in terms of our community approaches that can actually reach the people that are disproportionately affected, often folks from Black and brown communities. So I wanted to just bring Marc in, because I know that we've been doing some work in London that it'd be great to share, and then maybe I'll ask Ace to just come in with a little bit around your approaches.
Yeah, sure. Thank you for that. I mean, I think the two examples that I want to kind of give is the work. Well, first of all, the work that the Love Tank has done directly working with local clinics in London, in particular regions, this was a while ago, this was back in the summer, but to secure a small amount of vaccine and to go to specific events where Black and brown queer men are gathering. So we hosted an event back in August, I think it was, for South Asian men, which was a brunch that we did, and we bolted on the offer of vaccines, and we were able to vaccinate 40 people that day, literally by having it there and then where they were. But we were also quite careful about not promoting that really widely. We literally said, on the day, we've got some vaccine, it's upstairs, you folk can get it, because we knew that if we put it out on social media, we would be overrun by the people that needed it but didn't need it as much as these folk. And the second example was to work again in partnership with an NHS trust and go to UK Black Pride. And so for anybody that doesn't know, it's the largest gathering of Black queer people, one of the largest gatherings of Black queer people in this country. It took place, we worked with the organisers of that, with a clinic, and we had a bus there which provided vaccine on the day. And we provided a massive amount. Now, what was interesting about that was we got no pushback from anybody there. Men were desperate to get the vaccine. They were really happy that we were in a community space for them. And some of the feedback that we got was number one, I didn't know that I could get this and get this easily. Number two, and this was the biggest take home for us, we had a number of guys come up who were not registered with sexual health clinics, thought that treatment and vaccinations cost because of the notion that we had this hostile environment in this country, therefore you will be charged for treatment. So not only were we giving vaccines, and we were also able to give some advice and plug people into more broader sexual health services. And the final thing that we're now doing through our work with the Pan-London partnership work that we do is to start looking at specific targeted outreach to those men in the settings, in the spaces that they are at, and meeting them there. But then building on experiences like Harun's, you know, of lived experience, of having men who have been vaccinated, sharing those stories as well. I think those things are really, really key for us.
Thanks, Marc. Maybe I'll bring in Ace, and then maybe I'll bring in Harun as well, because I know we want to talk about the lived experience as well of MPV. Ace, do you want to just maybe comment on some of the ways in which you're approaching your work, and maybe some of the successes and the challenges around the work you do in the communities?
Great. So when it comes to on the ground, the work that we were doing with some of the clinics, there were two models that we're seeing. We call it the New York model and the San Francisco model within the US. The New York model was, as Murray just spoke to, it was a buckshot of information that went out. The times that were available to get your MPV vaccine were often bankers' hours. So it was like the clinics were flooded with white gay men seeking preventative care. In San Francisco, what they did, which we've copied, like blatantly copied, we worked with the health departments who were providing the vaccines to control the appointments. So if at the beginning, as Murray said, there was a shortage. There were 50 appointments. We controlled 35 of them. And we work with our community to make sure that we are engaging people who are street involved, meaning like living on the street and or trade sex industry, and then also Black, Latino individuals, to make sure that they were the ones who were first in line. And the US, there's this term called trickle down, like as an economic term. So we were like trickle up, like the people with the least, making sure that they were supported first. Then people had a little bit more, then a little bit more, and a little bit more. And that was the model that we used to be very clear that we were trying to support those individuals, that if they acquired MPV, that the likelihood that they were going to either get diagnosed appropriately, because this is a longer conversation about systems, but understanding medical systems, we had a problem with people being able to be identified for MPV in real time, because all of the pictures of MPV etiology were all of people who were melanin challenged, like white-skinned individuals. So people who are darker skinned like me, there were no pictures of what it looked like, whether it was anal, urethral, oral. There were no pictures of what that could look like. So making sure that we are working with our clinicians so that they could identify MPV in real time and then start treating. So there were a lot of moving parts to make sure that this went appropriately. And then there's a question in the chat saying like considering the data analytics about unequal treatment, what could we be doing differently? What we have to do differently is it's an American term called HEDIS standards. But what all HEDIS standards means is that you have to do this in order to get paid for your patient showing up. Whatever you want to call that, wherever you are, if the clinician doesn't do X, they don't get paid for X. So like if you come in and like you're going in and you're presenting with some skin lesion or something like that, if the clinician didn't screen you for MPV, well, you're not going to get paid for any evaluation that you did of that individual. Those types of things takes the subjective part of clinical care, the part that we were speaking about around U equals U, around PrEP, around treatment, all that stuff that's about subjective treatment, taking it out of the hands of the clinician and saying, you like money. Most clinicians like money. I know your clinic administrator likes to be paid for when a patient comes in. If you don't do this thing, you're not going to get paid for that patient showing up. It's just like you were wasting your time. So take that out of the hands of the individuals and make it as clear as possible, because until we address racism, queerphobia, sexism, ableism, and all those things, they're going to exist. But while we're working on all the social ills, let's just make it an administrative fix and say, you're going to have to treat your patients equitably, even if everything inside your gut says, oh, well, this is a white gay man, so let me screen them for MPV. This is a non-gay identified man, sexual minority male, so let's not screen them for MPV.
Thank you, Ace. And yeah, thank you for explaining those number of different approaches. I really like the word trickle up, particularly because, yeah, definitely at the moment, there's a bit of talk in economic circles about the old trickle down, which doesn't work. So I'm going to definitely remember trickle up. I really like that way that you.
Oh my God, I totally forgot to answer the other part of the question, and I apologize. What we're doing in the US right now, we're pushing a bill for funding around MPV. Part of that bill is to make $600 million of the $4.5 billion. $600 million of it will go to the global efforts to mitigate this before it becomes a full pandemic, like trying to make sure that we're supporting those West African countries, Central African countries, where MPV has been endemic for the last 5 decades. Sorry, I forgot to add that part.
Great, thank you. And I think we may well just come back. There's another question in the chat about the situation in Africa. But let me just bring Harun in, because I really wanted to just in a way check in with you, Harun, about you had a kind of lived experience of acquiring MPV, and I'm aware that we've had somewhat of a targeted approach around trying to get people vaccines who might have been at risk of MPV. But I wondered, from your perspective, what has it been like acquiring something that's felt very new, very uncertain? You've had quite a journey around what happened to you. So, I'm aware we've not got loads of time today, but I'd just like to bring in a flavor of, maybe what you'd like to highlight from that kind of on the ground lived experience.
Thank you very much, Joel. First of all, I have to say that I think I suffered the lack of communication from authorities at the beginning of monkeypox, clearly, because I really struggled to access to help for 2.5 weeks. I called emergency services 5-6 times when I was, at home with plus 40 degrees Celsius fever. And every single time, even if I mentioned them, it could be monkeypox. I've been asked same 5 questions. Did you hit your head? Do you have any blood somewhere? Did you pass out? And I said, no. They said, no, you are not an emergency. So it took so long. And I was misdiagnosed 4 times because there were no information to the frontline workers about monkeypox, about the symptoms of it, about how to test it, what to do. So unless you are going to a sexual health clinic or calling a sexual health clinic, A&Es, emergency services, or any other departments had no clue. And I'm talking about June. First monkeypox case was on 7th of May in 2022 in the UK. And in June, I think 13th of June, I got sick. And 20th of June, I was still trying to get to the hospital. And COVID, tonsillitis, and even my GP called me, said that your HIV medication stopped working probably. And that was the reason they passed me over to a sexual health clinic. And but nobody thought about monkeypox. They had no idea about it. And after I got out of the hospital, my GP called me to ask about monkeypox to me, to a patient. So that showed the level of communication actually passed through the different departments of the healthcare. And the only information I could find at the beginning was through the organizations and unknowns. And getting this diagnosed, test result, positive test result, was maybe the best thing happened to me after 3 weeks of really suffering and pain and the lesion and not knowing what is happening. And after that, I was put on tecovirimat, and first sign of healing came in 4 weeks' time. But this showed me that we learned nothing from HIV over the years, I think, when it comes to managing the public health. I hear from many people, especially since I started to share my journey, so many people are contacting me, asking me questions, and I'm hearing from them that still some in the UK, in their words, in quotes, I was kicked out like a garbage bag because they don't know how to handle an infectious disease in certain hospitals or in certain clinics, maybe. So this just boosts the stigma. And we had the same thing, exactly the same thing with HIV. When the pharmaceuticals were trying to make money from it, when there were no solution and inequalities all around the world, and certain communities were affected, and we immediately labeled it as a gay disease, and we blamed sex. And I still think that people who doesn't have sex enough blame it everything on sex. But and I was some of the responses from community and from people were like, I was promiscuous, I was just can't keep my pants on, I had HIV, I had COVID, and I am gay, so I deserve to have monkeypox. This all comes through miscommunication or lack of communication, and then pushing certain aspects of a condition rather than telling people the truth straight away. We are having the same struggles with vaccine right now. We are trying to figure out when vaccine stock going to be arriving. We don't get the response. That just boosts up stigma. And I must say, from my experience, many people said that I learned many things from you. But right now, especially around the dating apps, I'm talking people who are not in the community, not following gay Twitter, and they are saying that, what is monkeypox? So that shows that while we are trying to fix something, we always save the day, but sometimes we miss the bigger picture. When we are vaccinating, we forgot the sex workers, we forgot the people who are really at high risk or living with people who had monkeypox, and then we run out of the stocks. These all things just really built up in the community, again, bringing the fear that what we saw from HIV, and then again, running to the voluntary sector. So my experience kind of opened my eyes again. I understand people like Marc and Susan over the years, going through, and they opened up the path, and we are very comfortable right now with new treatments and HIV developments. And I just didn't want to go through the same path, and I just wanted to take an early action on a personal level. But yeah, basically that was the struggles of having a really, and also the last thing I have to add, people blame me for being a crisis actor. I am telling everybody that my CD4 levels were 1300. My doctors think that I have a very robust immune system. even with someone living with HIV or not living with HIV, and I had it severe. So I shared my experience not to scare people. I shared my experience to at least tell people to be kind to each other and to be considerate to each other, because we don't know who may get it severe. So we have to think about, we have to be our good advocate of our own health, and we have to protect each other, because obviously it showed that nobody else will protect us unless our community does. So
thank you, Harun. Thank you. And I mean, one thing I really noticed about you sharing your story, Harun, is that I think, you know, when people with lived experience of a stigmatized illness speak, it's just does wonders for that stigma. You know, the bravery and also the dignity with which you've spoken and you comment and you share your story. It just has a massive effect. So thank you.
It does. Thank you, Joe.
Joe, can I just jump in? Can I just jump in really, really quickly, because it's literally off the back of what you've just said there about Harun sharing his story and the power of that. But I just want to kind of reflect on something for just maybe 30 seconds. Is that Harun's case is not unusual in that notion of so many people, and I had lots of messages because of the work that we were doing from particularly Black queer men who were diagnosed or were misdiagnosed or really confused. And I think what we also need to bear in mind is that Harun has, I hope you don't mind me saying this, Harun, a certain amount of agency and is plugged into the sector and is able to get online and to talk about these things. And I commend you for that, my friend. But I also know there were so many people who are already plugged into the system and don't have that language to do that and are unable to have a voice regardless of their HIV status. And I think that was the other thing that was being layered on here, that there were so many people who were just moving around in the absolute dark already, and this just exacerbated all of that. So I think, again, that the community response did help some of those people through. So it's just to put that in.
Yeah, that's great, Marc. And it's great to hear that at least there's somewhere to reach out often. But I think one of the things that is so stigmatizing about MPV is not only the lack of information, and also sometimes just inaccurate information, and then being, like Harun said, put from pillar to post in terms of, going to the healthcare system and not really knowing what it is. But a lot of the stigma has come around the isolation period, the types of symptoms, the questions around transmissibility, partner notification. And I was just wondering, I wanted to see if I could bring Susan and Murray in to talk a little bit about whether around the stigma, and whether you feel that what we know now around the transmission in the sexual context with gay and bi men who have sex with men is a bit different to what we experience in places where maybe there's more household transmission. So I just wondered if you had a few comments for us around that. Like, are we looking at something that is a bit different and can be a lot more severe, or is that a sort of false parallel?
I certainly think that there's a great deal of stigma around monkeypox, but I think quite a lot of that comes from misinformation and miscommunication. And often it's the language that's used around monkeypox, around MPV, as we saw with HIV, when we talk about spread and words like that. So I think we have to be really careful about the language that we use. And it's really important that the information is clear, accurate, and reliable, and coming from sources that people actually trust. And I heard from the WHO today that we're not so much in Europe, but we're seeing an increase in cases of MPV in women in the Americas. And I do wonder if actually there are even more cases than are being reported because women aren't being told about the symptoms. And I absolutely recognize that it's really important to have a communication aimed at the people who are most affected, in terms of people from gay communities, but also we need to realize that there are people who potentially are being exposed to monkeypox that just aren't getting information. So it's really important that the information is shared more widely. And women are so often ignored where it comes to sexual health messages. And I think there might be an assumption that actually, women aren't getting it because of the type of sex that we're having, but I'm sure there are women who are contracting MPV sexually as well. So we need to have information that isn't stigmatizing.
Yeah, thank you, Susan. And if we're to learn anything from HIV, it's that, an infection is an infection, and that human beings behave as they behave, and we all have contact with each other often. So, I think we ignore at our peril, don't we, the fact that probably there is much more further transmission and infection, and that people have not got access to the information. Maybe they have the infection and then, they feel a bit ill for a while, and then it moves through, and they just don't even know they've had MPV. So, thank you for bringing that in. I know the data in the UK is like really heavily skewed to gay and bi men who have sex with men, but there are some women who've acquired monkeypox. There's a bit of an overlap with trans women in those figures, but like you say, there must be people who are acquiring MPV and just don't know that, about it, and they don't know they have it. So, Murray, do you want to?
Yes, Susan, those are great comments, and I would add to that at least in Washington D.C. in the early part of the outbreak in June, late May, early June, I think there was a tendency to even reach out and educate gay men in particular, who were primarily, who was being impacted, because there was a worry that if we do that, it's going to stigmatize, right? So it's going to be stigmatized as a gay, disease or whatever. And so I think there was some reluctance early on to reach out to networks, to talk to networks, with, as you say, Susan, the trusted experts reaching out and providing harm reduction messages, because I think that was really important. Well, I think it's still very important. But early on with the vaccination shortages, we needed to be getting that harm reduction messages out to gay men who were the ones primarily, contracting monkeypox, MPV. And so I think there's been a reluctance to go there, to not stigmatize. And I think we've gotten better about that. Our government has certainly gotten better about that in the US. I do think, as Ace said, having Dr. Dimitri Daskalakis as the deputy coordinator at the White House has been really important, because there has been a focus on harm reduction, on making sure the information is getting to the populations that are impacted, and as well an emphasis on getting vaccinations to those populations, targeted vaccination clinics, targeted events, where Black Gay Pride is a great example in Atlanta recently, where the government allocated vaccinations there. I think it was about 5,000 vaccinations, and I think 4,000 of them were actually given out to people at that event. And so I think there's a reluctance, again, summarizing the stigma question, a reluctance to get the information out, because we're afraid sometimes that we are going to stigmatize in that outreach.
Thank you. Thanks, Murray. I just want to check with Susan, because you're still unmuted. Do you have a follow-up from that?
Yeah, no, I agree absolutely, Murray, and I think it's really important that there is no value judgment, and that the messaging is sex positive.
Mm-hmm. Great. There's a question from Julie in the chat, which I think is probably a good one to sort of like focus on as we near the ending. We're sort of 8-9 minutes away from the end of the session. And, Murray's been talking a little bit about it. So I guess the question's asking, in a way, where are we with vaccination? And, I see vaccination as obviously part of a harm reduction approach. So, the question is a great question from Julie, sort of saying, where are we with harm reduction messages? Are there examples of harm reduction campaigns? And are they yielding some positive response? And I've certainly seen some data that looks like communities are really responding, and they're making different, people are making different decisions about various things, and certainly people are going in their droves to get vaccines. So, you know, clearly people, when they know the information, they are really motivated, and they want to, you know, reduce the likelihood of getting MPV. So, yeah, I wonder whether we might just hear from each of you around Julie's question and some of those, you know, in a way, where are we right now, I suppose, sort of right now and looking to the future, I guess.
So, hey, Julie, thank you for the question. So this is a two-part question. The first part is, yes, the harm reduction messaging for the people who are well connected with healthcare entities, who trust the healthcare entities. There has been a reduction in sexual partners or the type of engagement people are having in public spaces or in some sexual spaces. And then I think what we were speaking about earlier, that does not apply for people in the trade sex industry, individuals who are living on the streets, individuals who have less control over their sexual activity as compared to other individuals. That harm reduction method will fall flat on its face. And then going back to what Marc, Harun, and I were saying earlier about our communities are not aware of MPV. This is a conversation that's a very esoteric conversation we're having today. Like, whereas the people who are most impacted don't know MPV exists, don't know this conversation is happening, and don't know anything about harm reduction methods. So there's that part of the conversation that is vital to who is reducing sexual partners or the way they're engaging in pleasurable sex. And then the individuals who are not necessarily having pleasurable sex, people who are having survival transactional sex.
Thanks, Ace. Yeah, some really hard-hitting points again, and it's also reminding me of the question from Pank in the chat about prison populations. You know, and really there are all these different kinds of folks who are affected, aren't there? And often people get really disenfranchised and they can't get the information they need. Okay, let's see.
Part of the conversation, just want to make sure we circle back, because this is a global conversation. When we're looking at where the deaths are, Nigeria and Ghana, like, combined equal the rest of the world. So when we're talking about, if you think you're living with MPV and you do nothing about it because you're worried that, you know, you have anal lesions or something to that effect, you can't go to the clinician because you're worried about what will happen thereafter. This is a huge conversation. And like, even when you look at the numbers, just, you know, I was living in Senegal when we had an MPV outbreak in about 20 years ago. And it was all men. And I was like, well, that's interesting. That is all men. It was all like, you would assume there'd be at least one cisgender woman who was being diagnosed, and like having those conversations about what does it mean when you have to be in the closet for your survival. Some of it for your literal survival, some for your professional survival, some for your familial survival. It's a huge conversation. And like, so, and the question about prisons, within the US is a very US thing. It depends on the prison. The same prison that is offering condoms and offering PrEP is also screening people for MPV and supporting individuals who acquire. The same prisons that are denying condoms and denying PrEP are not offering MPV screening and MPV treatment in an active setting because of like how they'll be treated by the guards, how they'll be treated by the other inmates. There's a lot of those pieces that comes to how do you judge a healthcare environment? Look at what they're doing with their prison population, and that's how you should judge them.
Thank you, Ace. We have got just a few minutes left, so any final comments either on Julie's question or Pank? And also I know Ace has brought in you know, this question about global health equality as well.
Yeah, I mean, I just want to come back on to just following off on what Ace has said there, and I think there's a couple of things. I think first of all, regarding the harm reduction stuff, it really does rely on what you know about MPV already. And also one of the biggest things you can about harm reduction is it's about acknowledging and understanding that this impacts you, right? So why would you try to reduce the harm if this is something which is happening to people that don't look like you, that aren't part of your sexual networks? And so even if you know about MPV, if you think it's affecting cis white guys of a certain age over here, and you're a black guy only having sex with other black guys who are in their 20s, you know, we saw this with HIV for many, many years. And so I think that's absolutely a key point there. So harm reduction, one of the key things of harm reduction is understanding that this impacts your community. And I think the second thing is it links to what Ace is saying, back to that, what was going on in the African continent. And this is one of the issues we have around men accessing vaccine here, is about, am I outing myself? If I say I'm going for an MPV vaccine and I live at home with my parents, what does it mean? And if I get MPV and I live at home with my parents, what does that mean? Because we're sharing bedding, we're sharing toweling. There's all of these factors which are just not being considered. And the whole notion is that it is urbane, independent, privileged, not even privileged, but these just independent men who can do this in their time. And there are so many of our community who do not fit into that bubble. And until we address that, then we're going to be in the situation that we continue to be. And I think, Joe, as you were saying, that our figures in the UK is at something like 9% of MPV cases are in men of colour.
Yeah, thank you. Thanks. Thank you, Mark. Great points. Who wants to go next?
I'd just very briefly like to say that 3 cases have been reported in a refugee camp in Sudan at the moment. So we're going to see monkeypox get much worse globally. We cannot forget also that there have been 23 deaths globally, yet there's been so much of a focus on what's happening in Western countries. And I think it's crucially important that countries, particularly where monkeypox is endemic, have access to vaccines and are given the recipe to make their own vaccines, not just have handouts.
That certainly sounds like a manifesto for sure. Thank you, Susan. Yeah, great. Murray?
Yeah, and I will just add one more thought on the harm reduction messaging, because I do believe that when communities come together and speak out, there is a very, very, very effective harm reduction response. And I'll give a couple of examples. One of the things that I mentioned early on was our community and a lot of different communities coming together. Several of us organized different sessions, Zoom sessions, in-person sessions, and we brought an expert in who knew something about monkeypox, and we just had discussions. And that was very, very crucial, I think, in allowing people to make their own decisions based on their own behaviors as to what they could do to reduce their harm. And so I do think we've seen some examples of very effective harm reduction. Yes, I know more needs to be done, but I think that that community aspect and that educational aspect with trusted experts and peers of the community is really important.
Great, thank you, Murray. And I'm going to give the last comment to Harun. We've talked a bit about what is going on in your decision making. How are you making decisions now that you've acquired MPV? We don't know about how long the virus stays in the body, and so how does it feel for you, Harun? What's the sort of focus for you around harm reduction? What would be useful, and what's helping you?
Well, I'm trying to bounce back and to find my mojo again. But to give myself a peace of mind. Now, in the UK, it is being offered as semen testing. So I gave a specimen and waiting because the researchers are very limited. So they will test it and tell if there are traces, and it will be highlighting other important parts of researches as well. So I just wanted to take it to give myself a peace of mind, because since the monkeypox, I don't know, and the scar left on my nose is still bothering me, and I kind of find myself in a place that the conversation always comes around monkeypox, and I'm answering the questions. So but on the other hand, I know that knowledge is power. So as much as we share, I know the other people will empower from that. So I'm taking it one day at a time. And I'm going to believe that I'm going to lose all my scars left from it, because I don't want any reminders of that. And I'm hoping to fully bounce back mentally, because physically I'm fine. But mentally, all this overwhelming unknowns is a bit tiring, exhausting. But hoping to recover fully very soon.
Thank you, Harun. And yeah, I'm just moved again that you talk so openly about, how it's affected you, how you feel physically and mentally. And, it's a sort of perfect note to end on, really. It's something that affects individuals and communities, and, it has a real life face to it in terms of your experience. And it's so crucial, isn't it, that we actually talk about our sex and relationship lives. You said about bouncing back, and I wish you all the very best with it, and I hope you feel just more yourself, and you're able to do what you want to do for the future as well. So thanks so much for being so open and sharing your lived experience with us today.
Thank you for having me over.
Okay, I think that is all we have time for, unfortunately. I found it absolutely stimulating, enlightening, absolutely cracking bunch of people to just spend an hour with. I wish we could have longer. And I just really wanted to thank you from GMI Partnership and the Love Tank. Just really wanted to extend thanks for joining us from all different places. And really just sharing the great work that you're doing. And I very much hope we'll meet again to discuss it. And, hopefully it won't be too long away as well. So, just wanted to, say thank you from me, and also GMI Partnership, and for the audience as well. There's been a few people posting saying how much they've appreciated everyone's answers and the insights you've shared. So thank you so much.
Thanks. Bye.
Thank you.
Bye-bye.
Bye,
Thank you.